A semi-private room in an American nursing home, that's a shared room with a curtain between you and a stranger, now costs a median of about $9,600 a month. Call it $115,000 a year. That's more than tuition at Harvard. And here's the part most families don't see coming. Medicare, the health program nearly every American over 65 relies on, pays for almost none of it. So who does? Follow the money through this roughly $200 billion industry, and you find one of the strangest financial arrangements in America, one that most people only discover in the middle of a crisis. For most of American history, there was no nursing home industry. If you got old and frail, your family took care of you. If you had no family and no money, you ended up in the county poorhouse, a grim public institution that housed the old, the sick, and the poor together. Two laws changed everything. The first was Social Security in 1935. It gave older Americans cash for the first time, but it deliberately refused to pay benefits to anyone living in a public poorhouse. Congress wanted those places to die, and they did. But the cash didn't eliminate the need for care. It just moved it. Private board and care homes sprang up to collect those Social Security checks, and a business was born. The second law came in 1965 when Congress created Medicare and Medicaid. Medicare is federal health insurance for people 65 and older. Medicaid is a separate program run jointly by the federal government and the states that covers people with very low income and almost no assets. Medicaid, not Medicare, became the program that pays for long-term nursing home care. Once the government guaranteed payment, developers built nursing homes at a furious pace. So the modern nursing home wasn't designed as a home. It was designed as a facility that could bill the government. That original DNA still shapes everything about how the money works today. Start with the national numbers. In the most recent cost of care survey, the median price of a semi-private nursing home room is about $9,600 a month. A private room runs about $10,800 per year. That's roughly $115,000 for the shared room and about $130,000 for the private one. And that's the median. Half of facilities charge more. Location changes everything. In Texas, a semi-private room runs around $5,700 a month. In Alaska, the most extreme outlier in the country, it can top $25,000. Now put those numbers next to what older Americans actually have. The average Social Security retirement check is right around $2,000 a month. So the typical benefit covers roughly a fifth of a shared room. The rest has to come from somewhere. What do you get for the money? The base rate generally covers the room, meals, housekeeping, help with daily activities like bathing and dressing, and around-the-clock nursing staff. But plenty of things can be billed on top. Extra therapy, special equipment, salon services, sometimes even incontinence supplies. One more distinction matters because it decides who pays the bill. The same building usually sells two different products. Short-term skilled nursing care is medical rehab, recovery after a hospital stay, a stroke, a broken hip. Long-term custodial care is help with everyday living for people who can't manage alone anymore, often because of dementia. Rehab stays last weeks. Custodial residents commonly stay a year or more, and people with dementia can stay for several years. At $9,000 or $10,000 a month, the difference between a 90-day stay and a 3-year stay is the difference between a big bill and a vanished life savings. And prices don't sit still. For years, nursing home rates have tended to climb faster than overall inflation, with jumps of 7 to 9% in some recent years. There are roughly 15,000 certified nursing homes in the United States, housing over 1 million people. About 7 in 10 are run as for-profit businesses, and the industry has steadily consolidated into chains, with private equity firms and real estate investors buying in. Here's where it gets interesting. Many nursing homes are legally split into pieces. One company owns the building, another operates the care. Others, often owned by the same people, sell the facility its management services, its therapy, its supplies. The facility pays rent and fees to its own sister companies. On paper, the nursing home itself can look like it barely breaks even, while money flows steadily out to related businesses. Researchers and government watchdogs have flagged this structure for years because it makes it genuinely hard to know how profitable these operations really are. Meanwhile, the biggest real cost is labor. Most hands-on care comes from certified nursing assistants who earn a median of around $19 an hour, under $40,000 a year for physically and emotionally exhausting work. Staff turnover in the industry is famously high, often around half the workforce in a single year. The government doesn't just regulate this market, it effectively sets the prices because Medicaid pays for the majority of resident days, usually at rates lower than what private customers pay. That creates a quiet hierarchy inside every building. Short-term Medicare rehab patients are the most profitable. Private pay residents come next. Long-term Medicaid residents pay the least. Facilities respond to those incentives when they decide which admissions to chase, and the incentives show up in outcomes. A widely cited study by university researchers found that when private equity firms bought nursing homes, short-term mortality among Medicare patients rose by about 10%, alongside cuts in frontline staffing. The industry disputes some of this research, and its trade association spends heavily lobbying against stricter staffing rules. But the basic pattern is hard to ignore. The fastest way to raise margins is to spend less on the people doing the caring. This is the section that surprises almost everyone. Medicare does not pay for long-term nursing home care. Full stop. What Medicare covers is short-term skilled care, and only under strict conditions. You generally need a qualifying hospital stay of at least 3 days as an admitted inpatient. Then Medicare covers up to 100 days per benefit period. The first 20 days are fully paid. From day 21 through day 100, you owe a daily coinsurance, $217 a day in 2026, unless a supplemental Medigap policy picks it up. After day 100, Medicare pays nothing. If what you need is help with bathing, dressing, and eating, which is what most long-term residents need, Medicare was never going to pay in the first place. So families pay privately. They drain savings, cash out investments, and often sell the family home. Private long-term care insurance exists, but relatively few people own it, and it covers only a small slice of the nation's nursing home bill. When the money runs out, Medicaid takes over, and Medicaid is the largest payer in this industry, covering roughly 6 in 10 residents. But qualifying usually means spending down your assets to around $2,000 in many states. Once you're on Medicaid in a nursing home, nearly all your monthly income goes to the facility, minus a personal allowance that can be under $100 a month. And after death, federal law requires states to attempt estate recovery, meaning the state can claim money from what's left, sometimes including the house. There's one more payer that never shows up in the statistics: family. Unpaid caregivers, mostly wives, daughters, and daughters-in-law, provide care that AARP has valued at around $600 billion a year across the country. Every month, a family delays a nursing home placement. That invisible labor is what's footing the bill. The sticker price is only where the spending starts. There's the fine print at admission. Families are often asked to sign as the responsible party, and some facilities have used those signatures to pursue relatives for unpaid bills. There's the hospital classification trap. If your 3 days in the hospital were coded as observation instead of inpatient admission, Medicare may pay nothing toward the nursing home stay that follows. Same bed, same care, completely different bill. Then there are the costs that land on the family. Adult children cut back hours, turn down promotions, or leave jobs to manage a parent's care. That's not just lost wages today, it's lost 401k contributions, the tax-advantaged retirement accounts most workers rely on, and smaller Social Security benefits decades from now. Caring for one generation quietly erodes the retirement of the next. There's the turnover tax. When half the aides leave every year, residents are constantly cared for by strangers still learning the job. That shows up as falls, pressure sores, and hospital readmissions. And there's the estate recovery surprise. Many families assume that once Medicaid steps in, the financial story is over. Then, after the funeral, a letter arrives from the state seeking repayment from the estate. It's legal, it's required by federal law, and almost nobody sees it coming. None of these appear in the monthly rate. All of them are part of the price. Step back and the design becomes visible. America never decided that long-term care should work like Medicare, something you earn and everyone gets. Instead, it made a different choice. Long-term care is your problem and your family's problem until you're impoverished. Then, it becomes a welfare program. Everything else follows from that choice. Medicaid pays modest rates, so operators hunt for margin through real estate structures, related party fees, and thin staffing. Care workers earn near poverty wages in a $100,000 a year product. And middle-class families experience the system as a trapdoor, too much money to qualify for help, nowhere near enough to pay for years of care. The demographics only tighten the squeeze. By 2030, every baby boomer will be 65 or older, and the population over 85, the group most likely to need nursing home care, is projected to roughly double in the coming decades. Meanwhile, boomers had fewer children than their parents did, which means fewer unpaid caregivers per aging adult. Other wealthy countries made a different bet. Germany, Japan, and the Netherlands run public long-term care insurance. Everyone pays in during their working years, and everyone is covered when they need care. Those systems have their own strains, but they don't require you to go broke first. So what does this industry actually deliver? For over 1 million Americans, it delivers something families genuinely cannot provide: round-the-clock care for people too frail or too sick to live at home. That's real, and it's not nothing, but the economics are built on a contradiction. The product costs more per year than most American households earn, the workers providing it earn some of the lowest wages in healthcare, and the biggest customer, Medicaid, only shows up after the resident has been drained of nearly everything. The people who own the buildings and the chains do fine. The aides, the residents, and the families in the middle carry the risk. If you remember one thing, make it this. In America, a nursing home isn't just where people go when they can't care for themselves. It's the place where the savings of a lifetime meet the price of living longer. And the price usually wins. That's the economics of nursing homes in America. If this helped you understand where the money goes, a like and a subscribe. Tell us to keep digging into the numbers. Thanks for watching.